Obsessive compulsive disorder, or very commonly known as OCD, is a common chronic and disabling disorder marked by obsessions and/or compulsions that are ego-dystonic and cause significant distress to the patient and their families. So this word OCD, we might have heard this word multiple times during our lifetimes, and also we might have actually used this word too. But in our day-to-day life, we have been using OCD without actually understanding the weightage of OCD. We might have heard someone saying, "Oh, I'm really OCD about arranging my closet. Oh, I'm really OCD about cleaning my kitchen." But they do not actually understand what real OCD looks like. Real OCD is very, very disabling. And these obsessions and compulsions are ego-dystonic. So ego-dystonic, let's see what the word ego-dystonic means. So ego-dystonic and ego-syntonic, these two words were initially used by Freud, mainly in psychoanalysis. So ego-syntonic explains or refers to behaviors, values, and feelings that are in harmony with or that are acceptable to the needs and goals of ego, or are consistent with one's ideal self-image. So any behavior or values which actually go along well with the self-image which we have created for ourselves would be called ego-syntonic, because they match with the ideal self-image we have created for us. Now, what is self-image? Self-image means how we perceive ourselves or how we see ourselves, while ego-dystonic means the exact opposite of ego-syntonic. That is, it refers to the thoughts and behaviors that are in conflict of person's ideal self-image. So ego-dystonic, anything that is ego-dystonic, it would cause very significant distress, because it is everything that the person does not want to be, and it is everything that is opposite to his self-image. And that is why OCD is very, very distressing for the patient. Much easier explanation of OCD is that it is a mental disorder in which a person feels the need to perform certain routines repeatedly, and these routines are called compulsions. Or he can have certain thoughts repeatedly, which are called obsessions. So the things we do or we act is called compulsion, while the thoughts which come in our mind are called obsession. So these obsessive thoughts come in our mind even when we don't want them to. Once they come in our mind, it gives us anxiety, it makes us anxious. And to relieve that anxiety, we perform certain routines which in the end are called compulsions. For examples, there can be an obsessive thought in a patient's mind that, "Oh my God, my hands are dirty." Or the thought is telling him, "Your hand is dirty, your hand is dirty." And this thought gives anxiety to the patient. So now what does he do to relieve this anxiety? He goes and tries to wash his hands. And then the thought comes to his mind again, "Your hand is dirty." And he goes and washes his hand again, just to relieve his anxiety. And this then becomes the compulsive act. So the repetitive thoughts, unwanted repetitive thoughts, are called obsessions, and the actions we do to relieve the anxiety produced due to those thoughts are called as compulsions. So the person is unable to control either the thoughts or activities for more than a short period of time. Some of the common compulsions are hand washing, checking the door lock, arranging things in a certain manner, etc. Most people who have OCD, they understand that their notions do not correspond to reality. However, because of these obsessive thought and these obsessive anxiety producing thoughts, they feel that they must act as though their notions were correct just to relieve the anxiety produced by those thoughts. Now, OCD can sometimes manifest without overt compulsions, which are referred to as primarily obsessional OCD. OCD without overt compulsions may characterize as many as 50 to 60% of OCD cases. So to say that people rely on compulsions as an escape from their obsessive thoughts. However, they are aware that the relief is only temporary and that the intrusive thought will return very soon. Some people use compulsions to avoid situations that may trigger their obsessions. So although there are people who can do certain things over and over again, they do not necessarily perform these actions compulsively. For example, if you're learning a new bedtime routine or if you're learning a new type of skill or a religious practice, it's not compulsion. So whether or not the behaviors are compulsions or are mere habit depends on the context in which the behaviors are performed. For example, arranging and ordering books for 8 hours a day would be expected out of someone who works in a library, but would seem abnormal in other situations. For example, or in other words, we can say that habits tend to bring efficiency in one's life, whereas compulsion tends to disrupt it. So in addition to anxiety and the fear that typically accompanies OCD, sufferers may spend hours and hours performing such compulsions every day. In such situation, it becomes very hard for the person to fulfill their work, family, or social roles. And it can also sometimes lead to adverse physical symptoms, like washing your hands multiple times with a very strong antibacterial soap can make your skin red and raw, and it can cause dermatitis. So people with OCD can sometimes use rationalizations to explain their behavior. However, these rationalizations do not apply to the overall behavior, but the instance individually. For example, a person compulsively checking the front door may argue that the time taken and the stress caused by one more check of the front door is much less than the time and the stress associated with being robbed, and thus checking is a better option. So in practice, after that check, the person is still not sure and deems that it is still better to perform one more check. And this reasoning can continue for as long as necessary. So during the last 2 decades, there has been a resurgence of studies into various aspects of OCD, including epidemiological, pathophysiological, and pharmacological investigations. Moreover, algorithms for the management of these patients have been proposed. The progress in our understanding of OCD is an example of the investment in studies on selective treatments, advanced methodologies of imaging studies, the imaging studies which can be done both before and after the treatment, and the neurological aspects of OCD and OCD-related condition, all of which reflect the development of psychiatry in the recent years. So there are a lot of imaging studies which can be done both before starting the treatment and also once the treatment has done. So these imaging studies can be PET or functional MRI or MRS, which is magnetic resonance spectroscopy. So MRI usually shows, for the people who have OCD, it shows that the corpus callosum and the white matter are abnormal in their brains. The PET and the functional MRI can also show increased blood flow and metabolic activity in the orbitofrontal cortex or in the limbic structures or in the thalamus and etc. And this is predominantly in the right side of the brain. So now if we talk about the neurological aspect of OCD, the neurobiology of OCD is still being sorted out. But the current perspectives suggest that the root of OCD are problems with communication between three brain areas. The three brain areas are the cortex, the striatum, and the thalamus. That is, the cortico-striatothalamic pathways. This is also called the CSTC loop. So over the past 25 years, there have been certain non-invasive imaging approaches, and these have consistently identified abnormal patterns of activity in the CSTC loop or in this particular circuit. And these studies have been highly influential in synthesizing the modern views on the neurobiology of OCD. Perhaps equally important over this span were emerging views on the basal ganglia circuitry functions, such as the description of numerous parallel and partially closed loop through the CSTC pathway proposed to subserve discrete motor or cognitive functions in a person's brain. So this model has been revised to incorporate the proposed opposing functions of the direct versus indirect projection pathways of the basal ganglia, as well as the compartmentalization of function with respect to the neurochemically defined striosome and matrices. To the early 1980s, OCD was considered as a treatment refractory or a treatment resistant chronic condition of psychological origin. Dynamic psychotherapy was of very little benefit, and several pharmacological treatments were attempted, but without much success. Since then, several researchers have reported that the prevalence of OCD is around 2% in the general population, or I would say it's 2 to 3% in the general population. So in addition, numerous studies have reported on the efficacy of various serotonin reuptake inhibitors or SRIs, and consequently an understanding of the biological basis of OCD has begun to unfold. Whereas in the early 1980s, the OCD was considered more to have a psychological origin instead of a biological basis. The observation that clomipramine, a tricyclic antidepressant or TCA, with a serotonergic profile is effective in treating symptoms of OC has increased interest in the relationship between serotonin and OCD. The substantial evidence currently suggests that OCD is almost unique among psychiatric disorder, as only serotonergic medications appear to be effective in this disorder. For example, non-serotonergic drugs such as desipramine, a very potent antidepressant and anti-panic agent, are entirely ineffective in OCD. This specific response to serotonergic drugs have paved the way for further research on the role of serotonin in the pathogenesis of OCD in particular, and also in OCD-related disorders in general. So what is serotonin? Serotonin is a highly useful neurotransmitter to have in your body and brain. It has all kinds of important jobs, which it does, and which altogether makes us balanced and healthy. So people who suffer from anxiety or anxiety disorders like OCD have often low levels of serotonin in their body. So serotonin, if not completely, it is at least partially responsible for regulating a lot of functions in your body, like maintaining your mood or, controlling aggressive reactions, Even your learning abilities are regulated by serotonin. Memory also is affected by serotonin as well as appetite and sleep. So serotonin plays a very, very, very important role in regulating a lot of functions done by your brain. So this is the reason why antidepressant medications, which are usually the SSRI, that is the selective serotonin reuptake inhibitors, or SRI, or the serotonin reuptake inhibitors, are the most commonly and most effective, commonly prescribed and the most effective drugs, medications which are used for OCD. Now, researchers also know that OCD is triggered by communication problems between the brain's deeper structures and the frontal part of brain, like we talked about earlier, the CSTC circuit, which is the cortical striatal thalamocortical circuit. So when there is a communication problem in the circuit, that leads to OCD. So these are the parts of brain which primarily use serotonin, which is a neurotransmitter, to communicate. And this is why increasing the level of serotonin in the brain can help to alleviate OCD symptoms. So now that we know what OCD is, let's talk about the incidence of OCD. The lifetime prevalence of OCD in the general population is between 2 and 3%, and therefore it is even more prevalent than schizophrenia. This rate has been confirmed across different cultures. The prevalence of OCD among children and adolescents appear to be as high as among adults. However, Nelson and Reisenstein et al. Have suggested that the diagnosis of OCD by the diagnostic interview schedule and administered by lay people leads to overdiagnosis. And so they have proposed lower prevalence rates of 1 to 2%. Both men and women are equally likely to be affected, although some reports have suggested a slight female predominance. During adolescence, boys are more commonly affected than girls. The mean age of onset is about 20 years of age. Single people are more commonly affected, probably representing the difficulty for people with OCD to maintain a relationship. So patients with OCD are commonly afflicted by other mental disorders too. For instance, the lifetime prevalence for a major depressive episode in these patients is about 67%, which is a very big number. Other common comorbid psychiatric diagnoses include alcohol use disorder, social phobia, specific phobia, panic disorder, and also eating disorders. The comorbidity with schizophrenia and with tic disorders raises interesting pathophysiological and therapeutic implications. The rate of tic disorder approaches 40% in juvenile OCD, and there is an increase in the prevalence of Tourette's syndrome among the relatives of OCD patients. The relationship between OCD and obsessive compulsive personality disorder, which is called OCPD, has been a focus of debate. Although prospective research is lacking, it appears that OCPD is not a prominent risk factor for developing OCD, as the prevalence of OCPD among patients with OCD is not far from its prevalence in other psychiatric disorder. Now let's talk about the causes of OCD. So as we talked earlier, neurotransmitters is one of the most important cause of OCD. So many clinical trials of various serotonergic drugs lend support to the hypothesis that a dysregulation of serotonin is involved in OCD. However, this does not necessarily reflect on pathogenesis. Abnormality of the serotonergic system, and particularly the hypersensitivity of postsynaptic 5-HT receptors, constitutes the leading hypothesis for underlying pathophysiology of OCD. The second neurotransmitter which is believed to be involved in OCD is dopamine. The most compelling evidence for dopaminergic involvement in OCD comes from the abundance of OCD symptoms in basal ganglia disorders, such as Tourette's syndrome or post-encephalitic Parkinsonism. The therapeutic benefits obtained with the co-administration of dopamine blockers and SRI in a subset of patients with OCD and tic disorders has also suggested a role for dopamine dysfunction along with serotonin, low serotonin levels. This provides further support for the hypothesis of reduced 5-HT activity and increased dopamine transmission in OCD. So the first cause of OCD are the neurotransmitters, and the second one are the immune factors. So study of autoimmune factors have been prompted by the association of OCD and the autoimmune disease of basal ganglia called Sydenhams chorea. Now, what is Sydenhams chorea? It is a neurological disorder of childhood resulting from infection via group A beta hemolytic streptococcus or GABHS. So this is the bacterium that is associated with rheumatic fever. Now, Sydenham's chorea or SC is characterized by aimless involuntary movements of arms and legs, trunk, and facial muscles. These movements can be rapid, irregular, and aimless. So Sydenham chorea is a complication of rheumatic fever. And sometimes it can lead to permanent damage of heart valves. But usually Sydenham chorea symptoms resolve within 3 to 6 months. The complication of this rheumatic fever is accompanied by obsessive compulsive symptoms in over 70% of cases. 10 out of 11 children had antibodies directed against the caudate lobe. So these children have a history of obsessive compulsive symptom which started prior to the onset of chorea, reached a peak in line with motor symptoms, and declined with their resolution. Now let's talk about what brain imaging studies have found out about OCD. The use of PET or positron emission tomography has demonstrated the presence of increased activity, that is, metabolism and blood flow in the frontal lobes and the basal ganglia, especially the caudate nucleus and the cingulum of the patients with OCD, like we talked earlier. The pharmacological and behavioral treatments purportedly reverse these abnormalities. The data from functional imaging studies are consistent with the data from the structural brain imaging studies. So both the CT and the magnetic resonance imaging studies have found decreased sizes of the chordates bilaterally. Both functional and structural imaging procedures are also consistent with the observation that neurological procedures involving the cingulum are sometimes effective in the treatment of patients with OCD. So overall, the brain imaging research suggests a role for the prefrontal cortex basal ganglia thalamic circuitry, like we talked earlier. Dysfunction of these circuits can be explored by neuropsychological testing and recording evoked potentials. A recent study of patients with OCD showed that they are slower in performing tasks involving frontocortical systems, suggesting alterations at this level. An evoked potential study showed enhanced processing negativity in the frontal cortex consistent with the prefrontal hyperactivity shown in the brain imaging studies. Now let's talk about the next cause of OCD, which is genetics. A significantly higher concordance rate was found for monozygotic twins than for dizygotic twins. Of the first-degree relatives of patients with childhood onset OCD, 35% are also afflicted with the disorder. Although this rate or this high rate is possibly related to the early onset subtype, it nevertheless suggests a genetic component in OCD. Now let's talk about other biological data that is related to OCD. So sleep electroencephalography and neuroendocrine studies have found abnormalities similar to those seen in depression, such as decreased rapid eye movement latency, non-suppression on the dexamethasone suppression test, and decreased growth hormone secretion with clonidine infusion. So for those of you who do not know what a dexamethasone suppression test is, it is a test that measures whether your adrenocorticotropic hormone, that is ACTH, secretion by the pituitary can be suppressed or not. So during this test, the patient usually receives dexamethasone, and this is usually a synthetic glucocorticosteroid which they receive, and later the blood is drawn so that the cortisol level in the blood can be measured. So it can be either done like a low dose test or a high dose test. So in a low dose test, so both these tests are usually done like overnight. And in the low dose test, you will get 1 milligram of dexamethasone at around 11 p.m. And then the healthcare provider will draw the blood next morning at 8 a.m. for a cortisol measurement. While in a higher dose overnight test, the provider will measure your cortisol on the next morning of test, and they would receive 8 milligrams of dexamethasone instead of the 1 milligram, which is given in the low dose test. So this overnight dexamethasone suppression test checks usually it helps us to see how taking a steroid medicine can change the levels of hormone cortisol in your blood. So this test checks for a condition in which large amounts of cortisol are produced by the adrenal glands, which is the Cushing's syndrome. So for the patients who have OCD, the DST or the dexamethasone suppression test usually has an abnormal result, and there is a trend for a patient with DST abnormality to have higher depression rating scale scores and higher incidence of family history of affective illness compared to DST suppressors. Now let's talk about the behavioral factors that can cause OCD. So according to the learning theory, obsessions are conditioned stimuli. When a relatively neutral stimulus is coupled with an anxiety-provoking stimulus, through conditioning, it will produce anxiety even when presented alone. The compulsions reduce anxiety, and the patient repeats them and learns them in order to avoid anxiety. So avoidance strategies are learned and a patient becomes fixed on it. Let's talk about the psychological factors associated with OCD, or the psychological factors which lead to OCD. The dynamic aspects of OCD were first described by Sigmund Freud, who coined the term obsessional neurosis. The disorder was thought to result from a regression from the oedipal phase to the anal phase, with its characteristic ambivalence. The coexistence of hatred and love towards the same person leaves the patient paralyzed with doubt and indecision. Freud originally suggested that obsessive symptoms result from unconscious impulses of an aggressive or sexual nature. These impulses can cause extreme anxiety, which is avoided by defense mechanism. One of the striking features of patients with OCD is the degree to which they are preoccupied with aggression or cleanliness, that is anal phase, either overtly in the context of their symptoms or in the underlying associations. So Freud described three major psychological defense mechanisms that are important in OCD. These are isolation, undoing, and reaction formation. So according to the psychoanalytical formulation, OCD develops when these three defenses fail to contain the anxiety. What is isolation? Isolation is the separation of the idea and the effect that it arouses when the patient is only aware of the effectless idea. Undoing is a secondary defense to combat the impulse and quiet the anxiety that its imminent eruption into consciousness arouses. Now, undoing is a compulsive act performed to prevent or undo the results that the patient irrationally anticipates from a frightening obsessional thoughts or impulse. Reaction formation is related to the production of character traits rather than the symptom formation, like the characteristics of above defenses. The trait seems highly exaggerated and inappropriate. That is, the switch of anger and hate into exaggerated love and dedication. So that was OCD, its causes and incidence. So for those of you who want to do more reading, you can go back and read the books that I have referred. And I will be uploading more presentations on OCD, its treatment and its diagnosis, and all the other aspects of OCD which we have not covered in this PowerPoint presentation. So stay tuned. Thank you.